much for your kind invitation. It's always a joy and an honor for me to speak about neuromodulation and all these really interesting therapies. The topic of my talk today is the role of Ziconotide in the intrathecal pain treatment. The agenda, I would like to say some things about neuromodulation. What is neuromodulation? What is chronic pain and how it is associated with neuromodulation? What is intrathecal therapy? And of course, what is Ziconotide? When I first started working in this field, I didn't really know what neuromodulation is. So I visited the official website of the International Neuromodulation Society, and I found there this definition. Neuromodulation is the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurological sites in the body. You can see there are many diseases that we can treat using neuromodulation. What is today important for us is pain. This is a huge list of surgeries that we can perform in the context of neuromodulation and try to help our patients. For today, this intrathecal drug delivery, intrathecal drug delivery systems or targeted drug delivery is our topic today. Chronic pain isn't something new. No, it's a very old story. In all countries, in Europe, in the United States, or in Asia, you will always find some articles in magazines or scientific papers there. And what do we see in the everyday practice? We see patients with these chronic pain conditions who are coming to us. Patients with trigeminal neuralgia or neuropathy and different types of headaches, for example, cluster headaches, patients with back pain, neck pain, arm pain, leg pain, patients after amputations with phantom pain or stump pain, patients with polyneuropathies, diabetic patients, patients with plexus lesions, with angina pectoris, peripheral vascular disease, postherpetic neuralgia, complex regional pain syndrome with or without capsalgia, and of course, tumor pain. What about the intrathecal therapy? I think you all have seen this ladder of the World Health Organization. Theoretically, we should start with non-opioids, then use the weak opioids, and then pass to the stroke opioids. In the end of this therapy, we have the intrathecal therapy. But we have seen that if we start offering our patients therapies like pulse radiofrequency or peripheral nerve field stimulation or spinal cord stimulation, before even trying with the opioids, then the clinical results are much, much better. Nevertheless, the intrathecal therapy stays at the head of this treatment plan. With the intrathecal therapy, and this is true also for spinal cord stimulation, we are working at the level of the second neuron. This is what we see in the operating room. This is how we place the patient in the operating room. At the same time, we can have access to the lumbar spine to implant an intrathecal catheter, and in the abdomen to implant the medical pump. This is how we should do the puncture using a needle. We are using also paramedian approach. We are placing the catheter with a tip somewhere between T4 and T8 under fluoroscopy, and we fixate this catheter. This is the gold standard worldwide. This is the synchromed pump from Medtronic. It's not publicity about this company, but this is what actually we have available now in Europe as a programmable pump. And you see that these pumps have a central port in order to refill these pumps, and a side port. Here we can make a puncture and we can aspirate cerebrospinal fluid, or we can give a drug as a bolus. This is what we see also in the operating room. You see the pump in the abdomen area, the instruments we are using, and here is how we are bringing the catheter from the lumbar area to the abdomen. This is what we see after the surgery. When we do an X-ray, we see this white spot on the X-ray. This is the tip of the catheter. Sometimes it's not so easy to find it. And a little bit of history of neuromodulation. Some years ago, we started with such pumps. These are pumps with gas, butane, inside. And this is the new version of programmable pumps. For example, IP2000 is produced here in Germany, the corresponding X-ray. Here we don't have a battery inside, we have a gas, and every day the patient is getting a specific volume of drug. The synchromed pump from Medtronic is a programmable pump, electronic pump. There is a battery inside, and this is why every 6 to 7 years we have to change the pump because the battery is empty. And which is the advantage of such a pump? The advantage is that we can have different infusion modes. With the gas pumps, we have only a simple continuous flow. With the programmable pumps, we can have a simple continuous flow or different combinations of both. This is particularly useful if we have patients with pain, let's say at night when they need much more drug. We can program the pump such a way that the patient is getting more drug at night. A very interesting paper, the Polyanalytic Consensus Conference, published in Neuromodulation in 2017. To keep it short, if you have patients with tumor pain, then you should start with the intrathecal therapy with or without opioids. If you have patients with non-tumor pain, then you should start with spinal cord stimulation or with therapies that are stimulating the nerves. A big issue now is that we are allowed to fill these pumps only with morphine or only with Ziconotide or only with baclofen. No combination of such drugs and no other drugs. In everyday life, we are using other drugs and we do use combinations of such drugs, but officially we're not allowed to do it. This is why the colleagues in the United States published this paper in 2019 also in Neuromodulation in order to raise awareness and to promote collaboration between FDA, pharmacies, manufacturers, and medical societies. And let's come now to Ziconotide. What is Ziconotide? It's a peptide out of 25 amino acid. It was originally isolated from the venom of the cone snail, Conus magus, as omega conotoxin. Of course, today it is produced synthetically. If you're interested in the topic, this is a review article published in Brain and Behavior. I think it's a good one, not because I'm the main author here, but it's a really good one. If you are interested in this topic, please have a look. And which are the advantages of Ziconotide? First of all, it's not an opioid. And if it's not an opioid, we don't have any respiratory depression. We don't have any tolerance. We don't have any withdrawal symptoms. Just say if the pump is not working properly, the patient will not have any withdrawal symptoms, and we don't have any endocrinologic abnormalities. Let's say you have a patient with COPD, then a drug which is not an opioid could be a very nice alternative. And this is a very old video coming back from 2009, shows the cone snail on the left side of the video, which is immobilizes its victims using its venom. It's really surprising to see how quickly it can do that. And this is an animation showing the action mechanism of Ziconotide. Normally, when we have pain in the afferent nerve endings, these calcium channels are opening, calcium is coming inside, and due to this calcium, we have the release of neurotransmitters. If we have neurotransmitters there, then we have transmission of pain to the brain. The role of Ziconotide now. Ziconotide can block these N-type calcium channels, and by blocking them, we don't have any calcium inside. If we don't have any calcium inside, we don't have the release of any neurotransmitters, and we don't have the transmission of pain to the brain. Ziconotide is a special drug. We should use it with caution. We have a principle, start low and go slow. Why? If we don't follow this principle, we could have some side effects. What type of side effects? Cognitive impairment, hallucinations, depression, suicide in susceptible patients who have also a history of suicide, or reduced level of consciousness. What we see in everyday life in some patients is the elevation of serum creatine kinase, and the most common adverse reactions are dizziness, nausea, confusional state, and nystagmus. It is true that finding the effective dose does take some time, and the patients should know that. Some issues, we know that the temperature, the altitude, and the light influence the stability of the drug. This is why the pumps must be refilled every 3 to 4 weeks when the drug is diluted with natrium chloride. And dilution is essential during the testing, but degradation of Ziconotide occurs over time due to the depletion of L-methionine in the pump. This graphic comes from the article that I showed you, which was published in Brain. It's important to keep in mind that for these patients, a neuropsychological evaluation of the patients is absolutely necessary. We should always check the creatine kinase, and we should always review the dose. We should concentrate on efforts not only on the pain reduction, but also on these patient-reported outcomes. If the patients have cancer pain, we don't have any maximum dose. If the patients have non-cancer pain, then we have a maximum dose of 19.2 microgram per day. And we think that it's better to start with a dose of 0.5 or 0.6 microgram per day and increase the dose once or twice per week. Red flags, and this is really important, a history of psychosis, of hallucination, of mania, or suicide. We do have our own clinical results. These data were published last week in the German Pain Congress in Mannheim, in Germany. And what is really interesting here is to see that the VAS score starts for 6 patients here from 8.5, and after 30 months, we're at 5.9. And you see the dose of Ziconotide, we start with 0.5, and after 30 months, we are at 7.9. If you make the maths, we are speaking about a pain relief of 30, maximum 40%. But please remember, these are patients who tried all other drugs and combinations, and they were not satisfied. So a pain relief of 30% is something important for these patients. What brings the future? We should work on these topics here, on the safety, efficacy, and clinical use in multi-drugs intrathecal regimens. We should work on the switch protocols from opioid intrathecal therapy to Ziconotide intrathecal therapy. We should also keep in mind that in different European settings, we have different titration strategies. An open question is where we should place the tip of the catheter, and we urgently need additional cost-benefit analysis, including patient-reported and health-related quality of life outcomes beyond pain scale measurements. Take-home message: there are concerns about Ziconotide, and these concerns must be investigated through sharing our clinical experience. This is really important what we are doing today. There is good evidence from the United States showing that the appropriate screening and low and slow dosing protocols can help to have an effective treatment without big problems. And in countries such as the United States, Ziconotide can help fulfill the unmet needs of management of chronic pain. And this is important in this global opioid epidemic. But this drug is not for all patients. This comes from a film, Modern Times, an old film, 1936, from Charlie Chaplin. Charlie Chaplin was working in a factory. He had to do the same movements the whole day in the factory. And if you do the same thing every day, then there are some complications. It's the same thing with our therapies. We should have many options and always try to find the best option for our patients and not the patient for the option that we actually have. We do need teamwork. This is a teamwork. It's not about a surgeon who is implanting a system. You always need a physiotherapist, a neurologist, a psychologist, and many, many other colleagues. That was all from my side. If you have any questions, I would like to answer them. Thank you very much for the invitation. Thank you very much for your attention.